My name is Jacqueline Nevols. I'm a consultant nephrologist. I now work in Portsmouth, and I was trained as a nephrologist to focus on blood pressure, blood results, all the dialysis parameters, etc. But I very quickly learned that focusing on numbers doesn't often make patients feel any better. Skin problems are a big problem for people with kidney disease, and it's only one of the issues that patients with renal disease suffer from. But there's actually a lot we can do to manage the skin care. There we are. So this is just a quick overview of our talk this afternoon. I'm going to talk to you about the skin and what it actually does by way of introduction, and then we'll move on to talk about the symptoms of dry skin and itchy skin. There's a few pictures of rashes which may be important to some of you for some things to look out for. And then the main section of the talk is about skin cancer, which can be a big problem for some renal patients. And we'll talk about how you can protect yourself from the sun and do your best to prevent skin cancer in the future. And at the end, I'm happy to take any questions. So we'll start then by talking about the skin and what it actually does. And it has a huge number of functions. The skin is actually the largest organ in the human body, and it acts as the body's first line of defense against a variety of insults. It prevents the body losing moisture and water, and actually acts as the body's own UV protection from the harmful rays from the sun. The skin is a sensory organ, and it allows you to obviously feel touch, pressure, temperature, vibration, texture, lots of different sensations. The skin also provides a huge role in temperature regulation for the body, and you can see in this schematic here the huge variety of blood vessels in the skin which can constrict, which means when you go blue and cold, so the body can conserve heat, and these blood vessels can also dilate to allow the body to lose heat. The skin is also a huge part of the body's immune system and plays a big role in the production of vitamin D, which I'll talk more about in the sun care section. And as physicians, we can actually use the skin as a way of administering medication, as sometimes tablets are not appropriate. And examples include patches, for example, for pain relief, and also for medication absorption, like hormone replacement therapy. And we mustn't forget that us humans actually use the skin as a social function. Some people are more attractive than others, for example, so it's really important to look after your skin. Let's talk first then about dry skin. Dry skin in patients with chronic kidney disease is called uremic cirrhosis, and it's really, really common. It can affect up to 85% of patients on hemodialysis, and also a significant proportion of people with CKD. Why does it happen? Well, in renal failure, the skin's sweat glands and also sebaceous glands don't work very well, and the skin can become dehydrated and start to look like this. Why is it a problem? Well, the skin can start to look flaky, and also some patients are really upset by the appearance of their skin. Not only is the look not as good as we'd like it to be, the skin can feel really irritated and also itchy. And because the skin's barrier function is disrupted, there is possibly an increased risk of infection, such as cellulitis. So what can we do about it? Actually, keeping the skin moist can be somewhat of a challenge, and we advise patients to use an emollient or moisturizer twice a day, every day. It's often best to apply skin cream directly after your bath or a shower, as this can help moisture be trapped into the skin. It's important to pat your skin dry gently after a shower to avoid irritation before you apply your moisturizer. It's also really important to use enough. A 500-gram tub, such as Balneum Plus, which I've illustrated here, should last just a fortnight. And patients I often find don't use enough or apply often enough, and it is quite hard work to keep your skin moisturized, but it is worth the effort, and it really does work with this method. So what are emollients that we use to soothe and hydrate the skin? Basically, we can subdivide them into three groups: lotions, creams, and ointments. And these are differentiated by the amount of water or lipid there are in each cream or lotion. Lotions have the most water content, which means that they're easiest to apply and are absorbed more easily. And there are many different varieties you can get in the supermarket or any chemist. A little bit thicker than lotions are creams, which are slightly less easy to apply but are more effective than lotions, and they do take a little while longer to absorb. And examples include Balneum Plus or Aveeno. Ointments have more lipid content, so actually they're quite tricky to apply, but they're very, very effective at hydrating the skin. They are quite tricky to absorb, so we often advise using these at night rather than using them during the day because you'll be sticky and slippery. Please be careful though that some ointments actually contain paraffin, which is actually flammable, so take care if you like to sit next to the fire. So let's move on now to talk about itchy skin. Itchy skin in patients with renal disease known as uremic pruritus, or more commonly chronic kidney disease associated pruritus. It's a bit of a mouthful. This is extremely common and in some cases can be significantly distressing for people with kidney disease. It can affect quality of life, and if severe, it can even stop you sleeping well and even lead to low mood. And in the past, it has been difficult to treat. So what causes it? Actually, there's been a lot more research in recent years, and we have a better understanding of what causes itching in renal disease, and it's probably a combination of these factors I've listed here. Renal failure leads to reduced clearance of some salts and toxins, which can then settle in the skin and cause itching. Some patients also have specific damage to the nerve fibers, which then lead to the sensation of itch. Abnormal opioid balance in chronic kidney disease is really common. Opioids, you may have heard of chemicals such as endorphins, which are the body's own opioid chemicals, which can lead to itching. We all know if you've had morphine, for example, in the past, that also causes itching. So how can we manage this chronic kidney disease associated pruritus? Well, I make no apologies for this slide, as some of the hints and tips on this slide may seem obvious, but not always to everyone. I sometimes see patients coming to clinic that are really troubled by their itching, but they're actually wearing a wool suit on a warm day, and it's no surprise that their itching gets worse. So let's go through these hints and tips. We've talked about moisturizing your skin in the previous slide, and it's really important if you're itchy to keep your skin hydrated. I'd also advise wearing cool, lightweight cotton clothing and avoiding any fabrics that might be irritating to the skin, and particularly wool. We advise to use lukewarm water when having your bath or shower, as hot water will dilate those blood vessels in the skin and bring more of these toxins and inflammatory proteins to the surface and cause more itching. Now, here's the difficult bit. We really do advise you to avoid scratching if you possibly can. Keep your fingernails short and don't buy a back scratcher, because adding additional trauma to the skin adds a cycle of inflammation, which actually makes itching worse in the longer term. But I do appreciate how difficult this is. I'd also suggest avoiding using soap if you can, as soap actually depletes the skin of its protective moisture layer, and try a soap substitute instead. As I previously mentioned, try not to rub your skin too much when washing. Just pat the skin dry after you've had your shower or bath. And if your relatives will let you, try and shower or bath every other day rather than every day, as that will give your skin some time to recover. So just back to scratching. Why do we try not to scratch our skin if we have uremic pruritus? This is why. The appearance of the skin can change significantly with repeated trauma due to scratching, and this is called nodular prurigo, which can be quite unsightly and can act as a route of infection into the skin and can take quite a while to heal. So this is why we avoid scratching if we possibly can. So what else can we do to help itching if it's persistent? Chronic kidney disease associated pruritus is actually a diagnosis of exclusion, which basically means this is what you've got if we've excluded every other possible diagnosis. And it's important to make sure there's no other treatable diagnosis, for example, eczema or even scabies or other itchy skin conditions. If you're on dialysis already, actually optimizing the dose of dialysis or dialysing a bit more, if appropriate, can actually improve the symptom of itching. We've talked first about hydrating the skin with emollients and skin creams, but if simple emollients are not enough, there are many creams on the market these days that have active ingredients in them, and there's some examples here. Menthol and aqueous cream is really effective, and it's even better if you keep it in the fridge so it's nice and cooling. And another one that I prescribe quite often is E45 itch relief, which contains a local anaesthetic called loramacrogol, and Balneum Plus contains these active ingredients too. However, a word of caution, there's no good evidence in the literature to suggest which cream is better than the other, so I would advise trying lots of different ones and find which one suits you the best. Let's talk about antihistamines. CKD-associated pruritus is not actually mediated by histamine. It's not actually an allergy, and antihistamines have been tried, but unfortunately in clinical trials, they've not been shown to be effective. That said, they're generally speaking well tolerated with minimal side effects, and some antihistamines are quite sedating, so may be useful at nighttime to help you sleep. Additionally, if there's any skin trauma from scratching, the inflammatory process from scratching can be mediated by histamine, so they're certainly worth a go. And if you're still struggling with itching despite these measures, there are specific medical therapies available that are now recommended in current guidelines. The only drug that we can recommend by mouth is something called gabapentin or pregabalin. Both drugs are related to each other. These drugs are actually anti-epilepsy drugs, and they stop the nerve firing in the brain if you've got an epileptic seizure. But the nerves in the periphery, in your arms and legs, for example, are made of the same stuff, and you can stop these nerves firing with using gabapentin or pregabalin, and they're very effective for itch. However, unfortunately, these drugs are renally cleared, which means that they do last quite a while in the body, and you have to start with a very low dose and infrequently, sometimes every other night. Please do ask your nephrologist if you'd be interested to try one of these. New research is coming out, and there's actually newer agents on the horizon, even given intravenously on dialysis sessions, that can help itching, so watch this space. So as I mentioned, CKD-associated pruritus is a diagnosis of exclusion, and it's not actually usually associated with a rash, but I've taken a few pictures here of various rashes which you may need to look out for and may be important to some of you. First one, this is vasculitis. Some of you may have been affected by vasculitis as a cause of your CKD. So vasculitis is an inflammatory condition which damages the blood vessels, which then leads to bleeding within the skin itself and causing this dark purple and dark red rash. It does not blanch under glass, and if you notice a rash like this, it's important to seek medical advice early, as this rash can affect other organs of the body and need prompt treatment. These examples here are drug reactions. The skin is hot, red, itchy, and inflamed. Looks really nasty, doesn't it? And typical appearances of this can occur with penicillin. That's a typical drug that can cause a drug reaction. It's treated usually with antihistamines and sometimes even with steroids. Unfortunately, once you've had a reaction like this to a drug like penicillin, the next time you take it, the reaction may even be worse. So it's important to not take the drug for the rest of your life. This is a similar kind of reaction. This is called urticaria. It's a similar allergic reaction, and it's otherwise known as nettle rash or hives. Again, it's mediated by histamine and can be treated with antihistamines, but it's really itchy. The last one here that I'd like to talk about is shingles, which I'm sure some of you may have had, particularly if you've had a transplant. If you're on medication to suppress your immune system or you're feeling a bit run down, this can allow the body to reactivate the chickenpox virus that you may have had as a child. The rash appears along the distribution of a nerve, often looking like a stripe across the body, and unfortunately it can be really, really painful. The pain can persist for several months, if not be permanent, after the rash has resolved. So it's really important, if you notice a rash like this, to seek help early, as early treatment with antivirals and special types of painkillers, in fact pregabalin or gabapentin, can actually lower the risk of permanent pain from this condition. So that's shingles, one to watch out for. So the next section of the talk is about skin cancer, which I know is a huge worry for some renal patients. It's important to know that skin cancer is actually the most common cancer after transplantation, often affecting up to 40% of renal transplant recipients, so it can be a big problem. And these are the risk factors for skin cancer that I'd like you to be aware of. The higher the dose of immunosuppression, these are the drugs for anti-rejection and to suppress your immune system, and the longer you've been on them increases your risk. Skin cancer is actually more common in white populations, and this is because white populations do not have so much melanin in the skin, which is the body's own protection from UV radiation. It goes without saying, and we all know this, that sun exposure increases your risk of skin cancer, and we'll talk about that in more detail in a minute. If you've had one skin cancer in the past, you are actually more likely to get another one in future, and this needs to be borne in mind if you're being worked up for transplantation. Men are more likely to get skin cancer than women, and actually they occur more often with advancing age. So why do transplant patients become more at risk of getting skin cancer? This schematic here just reminds us about UV radiation. There are two types of UV radiation, UVA and UVB. UVA radiation penetrates deeper into the skin, into the layers of the skin that provide the support structure for the skin. And actually over time, UVA can cause damage to these structures and cause aging. UVB actually doesn't penetrate that far into the skin, into the upper layers, and this is what causes sunburn. So UVA for aging, UVB for burn, just to help you to remember this in the future. Now here's the important bit. Both UVA and UVB can cause skin cancer as they damage the dividing skin cells and immune cells within the skin, which can then start to grow abnormally and form a cancer. So here's when immunosuppression comes in with transplant patients and those kidney patients that are on immunosuppression for other kidney diseases such as vasculitis. Your immune system is there to seek out and destroy abnormal cells. So intentionally lowering the immune system with these drugs can allow abnormal cells to grow. Some drugs are worse at this phenomenon than others, and I mention here particularly azathioprine has the highest risk among the common renal drugs. Now, please don't worry if you are taking this drug. It's a very good drug. It's been used by nephrologists for years, but please perhaps have a discussion with your nephrologist if you're worried about skin cancer in the future, as there are alternatives. Renal transplant patients are more easy to contract oncogenic or cancer-forming viruses, and the one you may have heard of is HPV or human papillomavirus, and this virus can lead to the formation of skin cancers and actually other cancers like squamous cell carcinoma of the cervix. So where does it happen? The common sites for skin cancer are on sun-exposed areas, particularly the backs of the hands, the scalp, particularly in balding men, and also the tops of the ears, which is an area commonly missed when you're applying your sun cream. Let's go through now the different forms of skin cancer that you may need to watch out for. Firstly, this is a basal cell carcinoma, or a BCC, otherwise known as a rodent ulcer. This is the most common skin cancer, in the general population, but actually renal transplant patients are 16 times more likely to develop a BCC than the general population. They present initially as tiny pearly papules with a raised edge that may grow with time and then become inflamed and ulcerate in the middle, like the bottom picture here. Although they can become locally invasive, they do not spread to the rest of the body, but they will not heal on their own and they do need to be removed. Next one to look out for is squamous cell carcinoma, or SCC. And this is actually the most common form of skin cancer seen in renal transplant recipients. Now, in terms... Oh. There we go, just get it to mute. There we are, sorry about that. So here's an interesting fact and quite a worrying fact. Squamous cell carcinomas are actually 250 times more likely to be present in a transplant patient than the general population. There's a big increase in risk if you're immunosuppressed, and this is why we worry about them. They present like these pictures here, red and scaly nodular areas within an area of sun-damaged skin, and they may actually become painful. If they do become painful, this may signify that they've invaded the lower areas of the skin where the nerves are. So it's important that they're treated promptly, as they may and they may spread to other parts of the body, particularly the lymph nodes. And then this is the worrying one. We've all heard of malignant melanoma, and this is the nastiest form of skin cancer. The risk is higher in men compared to women and with increasing age, but interestingly, they're more common in Black populations, which can make them harder to spot. Notice in the pictures on the right of this slide about the irregular outline of a malignant melanoma, and often areas of pigment within the melanoma look different to the next area, so a variation in colour. Those are the things to look out for. Now, unfortunately, malignant melanoma can spread to the rest of the body, and it often does so quite early, so these need to be spotted and removed as soon as possible. You may end up needing surgery and potentially other therapies like chemotherapy to treat malignant melanoma, but treatment these days is so good that the treatment can often be curative. So, what can we do to help prevent skin cancer, to look for it early and to get it treated? Firstly, be aware of it, like during our discussion today, and protect yourself from the sun as much as you can, and we'll come on to that in more detail in the next slide. At the end of the talk, I've got a link there to a video which shows you how to examine your skin properly to make sure these lesions are picked up early. Secondly, if you're at higher risk of skin cancer for any reason, your nephrologist may tailor your immunosuppression accordingly to lower your risk. And if you have any concerns, please do discuss this at your next clinic appointment. There are also things a dermatologist can do called chemoprotection. These are drugs that can be prescribed to patients that have had a skin cancer in order to lower their risk of having another one in future. And the examples include acitretin and nicotinamide. Unfortunately, these drugs are not always well tolerated, as they do cause very dry skin in some, and they're not suitable for use in women of childbearing age. Photodynamic therapy is an interesting one. The patient is given a drug that is actually light sensitive, and it travels to the skin and is activated under the presence of UV light in order to carry out the treatment. Lastly, and perhaps most importantly, is post-transplant surveillance. In some areas in the country, this is available on the NHS, and renal transplant patients and others at risk are seen by a dermatologist formally on an annual basis for skin surveillance. But unfortunately, in the current NHS financial climate, this service is not available, unfortunately, in lots of areas, and it's certainly not available in Portsmouth at present. So that's why it's important to look out for any changes in your own skin. This is what we're trying to avoid. This is sunburn. And if anyone comes to my clinic looking like this, I'm afraid they will get a bit of a talking to, but in a nice way. Please try and avoid your shoulders looking like that. So how to look after yourself in the sun. There are 3 things that you can do to protect yourself from the sun. Firstly, just avoid it altogether, particularly during the hottest hours in the middle of the day. And then always use a sun cream. I use sun cream every day going out. We have to look for one with a high SPF or sun protection factor, and we recommend SPF 50. SPF 30 is okay to use. It's not quite as thick as SPF 50, so it's easier to rub in and easier to use, but just be aware that SPF 50 is significantly better. Now, all sun creams have to be UVB protective as they protect against sunburn, but not all sun creams are also UVA protective. You need to look out for this little logo on the bottle to make sure they're also protective against UVA, because they don't have to be. And it's a star rating, 1 to 5, and try and pick one that's a 5-star rating. And then it will protect you from skin cancer as well as aging. We recommend that skin cream is actually applied at least 20 minutes before you go out in the sun, because it takes that long to work, and then try to reapply it every couple of hours, and particularly after swimming. If you can, try and find a lip balm that contains SPF, as the lips are often a site of some skin cancers, and also to protect your eyes is a good idea, as renal patients are often more at risk of cataract, and the more sun exposure you have, the higher the risk of getting a cataract later on in life. So treat yourself to a nice pair of sunglasses. Last thing is protect yourself from the sun just using clothing, and thinking about a hat is an obvious one, but you can actually buy specific sun protective clothing, and wearing a rash vest while you're swimming is a good idea. So all of these three mechanisms can lower the risk of sun-damaged skin, and they have been shown to reduce the risk of squamous cell carcinoma in renal transplant patients. As I alluded to at the beginning, the skin is a major manufacturing site of vitamin D within the body. So patients that protect themselves from the sun really well, and particularly those patients with darker skin and those who wear concealing clothing for cultural reasons, can actually become vitamin D deficient. Vitamin D is really easy to supplement. You can buy supplements like this from any supermarket, but please do check with your nephrologist first, as some patients may have high calcium levels or perhaps any other reasons where vitamin D therapy might not be appropriate, so do check. I do want to have one quick conversation about sunbeds. Okay, we all feel a bit better and may look a bit better with having a bit of a tan, but unfortunately, having a tan does not protect you from sunburn, and it does not protect you from getting skin cancer. In fact, it only provides very minimal protection from the sun. On the plus side, however, sunbeds have been shown to improve pain relief and also mood, but actually the effect that they give you is actually biochemically addictive. I think there are other ways, other methods of improving your mood and relaxing, because actually using a sunbed increases your risk of getting a melanoma by an absolutely staggering amount. And the risk is even higher if you start using sunbeds at a young age. And in fact, sunbeds are banned in most countries in children, and they're completely banned in Australia, where obviously there's more sun. So I have to conclude when we talk about sunbeds is that I'd advise you to think of other ways to relax. And just to finish the talk, lots of skin lesions crop up from time to time, and you may worry about them, that they may be a skin cancer. So I've just picked a few examples here of things that you may look out for but aren't actually a skin cancer. This here is an example of actinic keratosis, which basically means sun-damaged skin. It's really common, particularly on the scalp, and can be quite irritating for some. However, it is not cancerous and can be easily treated by the GP with creams such as Epidix and Aldara. These creams do help significantly, but the rash can look worse before it gets better and can become quite sore, but it is treatable. This one here is called Bowen's disease, which is otherwise known as squamous cell carcinoma in situ, so SCC in situ. This means that it's actually a precancerous condition, and if left for months to years, it can actually turn into an SCC, so it's important to recognise these. And interestingly, they often occur in the lower leg in women. This one here is called a seborrheic keratosis, bit of a mouthful, otherwise known as a seborrheic wart. They can occur on their own, or sometimes they can occur in quite large numbers, particularly over the skin of the back. Although perhaps a little bit unsightly, they are completely harmless and require no specific treatment, but it's actually sometimes quite tricky to tell the difference between a seborrheic keratosis and a malignant melanoma. So if there's any doubt, please seek help. And the last one here, we've all had these. These are viral warts. They occur really quite commonly in patients who are on immunosuppression and take absolutely ages to resolve, but they usually do so on their own, but it can take a year or more. To speed up resolution, there are many medications that you can paint on, or even have cryotherapy, which means freezing them off if they become troublesome. So we've talked about quite a lot in the last 20 minutes or so. Patients with chronic kidney disease and those on dialysis do have a lot of issues with their skin at times, but there's lots you can do to improve the appearance and feel of your skin at home. Please do check with your nephrologist at your clinic appointment if you're having itchy skin and having trouble with it, as lots more can be done these days to try and alleviate the symptoms. And I hope I've got the message across about staying out of the sun to protect yourself from a risk of skin cancer, particularly if you've had a transplant or on immunosuppression for other reasons. I'll just add a quick disclaimer at the end, is that I'm not a dermatologist, I'm a nephrologist, but I do have an interest in skin issues. Please obviously see your GP or talk to your renal team if you have any concerns about your skin. And I'll take this opportunity to thank you for the invitation to talk to you this evening, and thank you for your attention. I hope you found the session useful. And as I mentioned, I've included a couple of links here for more information about skin cancer if you find that useful. And also there's a video there on how to perform a proper skin self-examination. Thank you very much.